Understanding Substance Use Disorders, the Basics. This is a presentation by David Joel Miller, licensed marriage and family therapist and licensed professional clinical counselor. What do we call this field? Originally, there was a distinction made between addiction and alcoholism trainings. In some areas, it's still referred to as chemical dependency, but the more current term is substance use disorders as defined in the DSM-5 TR. The field of substance abuse counseling looks at substance use disorders differently than the field of mental health. This is a simple way of looking at the way in which clients may experience the various types of drugs of abuse. In this view, there are three main categories of drugs: uppers, meaning stimulants; downers, meaning depressant drugs; and all-arounders, which are drugs which alter perception. Uppers stimulant drugs include cocaine, the amphetamines, and caffeine. In mental health, there's one category on the forms in the DSM for amphetamines, but in substance abuse treatment, there will be two separate lines: amphetamines, meaning the pills, and methamphetamine, which is usually available as a powder, and these two drugs are often used in different ways. Downers, or depressant drugs, include the opiates, both natural and synthetic, and alcohol, barbiturates, and benzodiazepines. The all-arounders, the drugs which alter perception, include marijuana, PCP, LSD-25, and inhalants, deliriants, plus a growing problem in the area of new drugs is the introduction of many types of synthetics. There's a couple of exceptions to this three categories of drugs system. One is nicotine, which sometimes functions as an upper or stimulant and sometimes as a downer or depressant. This paradoxical effect is referred to as biphasic. Ecstasy, MDMA, and some of the synthetics also have properties of both stimulants and hallucinogens. The way in which substance use disorders are diagnosed by mental health professionals has changed recently. The textbook for diagnosing is the Diagnostic and Statistical Manual of Mental Disorders. The numbers in this book are from the ICD, the International Classification of Diseases. In the DSM-4, they had the categories of abuse and dependence. As a result, we spent a lot of time discussing with clients whether they were abusing drugs or they were alcoholics or drug addicts who were chemically dependent on the drugs of abuse. With the movement to the DSM-5 and now the 5TR, the way in which substance use disorders are diagnosed has shifted. We now look at, rather than addiction or alcoholism as a yes or no issue, the whole range of substance use disorders. Once a drug use problem is detected, it might be diagnosed either as a mild substance use disorder, more often called a misuse if it involves prescription medication, and moderate substance use disorder, which is roughly equivalent to the old psychological dependency. Severe substance use disorder would essentially correlate with what we used to call physical dependency or CD, chemical dependency. There's a huge overlap between people who use substances, misuse substances or develop a substance use disorder, and those with mental illness. Co-occurring disorders, that is, having both a diagnosable mental illness and a diagnosable substance use disorder, are an expectation, not an exception. Substance use disorders are a mental health issue or diagnosis. They're clearly listed in the DSM. Substance abuse counselors need to know some of the basics about mental illness and are taught to recognize and do a brief suicide assessment, to do a mental status exam. In substance abuse counseling, it's common to use the ASI, the Addiction Severity Index, which is covered in another course on substance abuse counseling. And they need to have some knowledge of medications and their abuse potential. In working with someone who may have both a substance use disorder problem and a mental illness, it's important to remember that substance use can look like a mental illness. For example, someone under the influence of a stimulant drug can be having psychosis. Substance use can cause a mental illness, and we have a category for substance-induced mental illnesses. And also, people who use drugs or alcohol on a regular basis become very attached. That becomes their primary relationship. As a result, people who give up drugs or alcohol can have the experience of grief and loss, anxiety, and depression. The chapter in the DSM on substance-induced disorders includes the use disorders, intoxication, or the symptoms you would expect to see of somebody who is currently under the influence, withdrawal, which was often the exact opposite symptoms you would see when they're intoxicated, and permanent long-term issues that are substance-induced. Substance use disorders, as diagnosed in the DSM, include 11 different categories: alcohol, caffeine, cannabis use disorder, which includes marijuana, cannabis, hashish, and hash oil, and then 2 categories for hallucinogens, PCP and other hallucinogens, inhalants. The diagnosis for opioids is a single category, regardless of whether the client is using street-type drugs such as heroin or prescription-type drugs. Also, sedative, hypnotics, and anxiolytics are a separate category. Stimulant drugs, whether those are cocaine, amphetamine tablets, or methamphetamine, and the newer synthetics, are another category. Tobacco is a separate category. And lastly, there is a category for other or unknown drug use or misuse. The DSM definition of a use disorder includes 11 different factors. I've rearranged the numbers to make them a little more closely parallel the way it's diagnosed in substance abuse treatment. The features, and I'm going to illustrate it here by describing alcohol. Alcohol use disorder has the characteristics of being taken in larger quantities or over a longer period of time than intended. That can be summarized as loss of control. The desire or effort to cut down or control. People who don't have a use disorder don't have a need to either curtail their use or control it. Lots of time spent getting it, using it, and recovering. And like all mental illnesses, it must interfere with roles either at work, at school, or at home. The other criteria for diagnosing a substance use disorder include continued use despite negative consequences, giving up or reducing social, occupational, or recreational activities, use in hazardous situations, continued use despite knowledge of the problems it is causing. Lastly, three characteristics that both substance abuse counselors and mental health counselors readily recognize as symptoms of a use disorder: tolerance, meaning needing more and more of a drug to get the same effect, or getting less and less of an effect when the same amount is used; withdrawal, which happens whenever they stop using a drug. Notice that in the DSM we have an antidepressant discontinuation syndrome, so some prescribed medications may have a withdrawal syndrome. But one of the key characteristics of use disorder is that the client has cravings for the drug when they're not in their system. The drug using experience can be affected by a number of factors: the drug's chemistry, the dosage, the route of administration makes a huge difference. Any drug swallowed and going through the stomach is reduced in potency by the stomach acids. The same drug inhaled in smoke or injected into the vein will have a stronger effect. Set, which means mindset, what the user expects to have happen, influences the experience. The setting in which it's used makes a lot of difference, whether a glass of wine is consumed in church for communion or the same glass is consumed in a bar late at night. We should also look at both the placebo effect, expecting a drug to do something positive, or the nocebo effect, when people are warned that a particular drug can be harmful, they often experience those effects. It's also important to be aware of the level of drug in the blood and combinations of drugs. Some other issues surrounding drug use which mental health professionals need to be aware of is an increasing trend towards recreational use of prescribed medications. For example, ADHD medications are almost entirely stimulant, amphetamine drugs, and so they're diverted and used either as study drugs or for recreational use. Another problem occurs when people who are using drugs become involved in multiple drug use at the same time, often called polysubstance, multiple substances. This is increasingly common, and we see different behaviors and different reactions when drugs are used by people in the younger age range, teenage to 20s, 18 to 25, or young adults. But also we're seeing a lot more use by children as early as elementary school. Some drugs can be used in small amounts or in medical settings and do not seem to be harmful, but there's a progression of use among people who eventually develop a use disorder. It may begin with experimentation, trying it to see what it is like. People who use a particular drug tend to socialize with other people who drink this or use the same drug. Alcoholics go to bars. People who smoke crack cocaine go to places where that's consumed. Beyond social use comes habitual use, where that's just what people and their friends do. They get together to smoke a joint or drink a beer or do something, other drug. But eventually this can turn into problematic use, some kind of a mild use disorder. Eventually that may turn into a psychological dependency when the person is deprived of their drug, they have cravings and a need for it, and in the ultimate stage of dependency, physical dependency develops. Drug use can lead to deaths from overdose. It can also increase illnesses. Drug use can increase medical expenses both for the individual and for society. We also have a very fuzzy distinction between medications and, quote, drugs. You go to a drugstore to buy medications, but you go to a drug dealer to buy what? Often medications and drugs, the only difference is the motive behind the use and where the person obtains them. Some other drug-connected problems involve crime. People may commit crimes to get a drug. They may commit them while they are under the influence, or commit crimes to pay for the drug. And as a result of needing money and the lucrativeness of the drug business, people become involved in drug dealing sales. There can be a correlation between domestic violence. The people who teach domestic violence trainings will say that, for example, beer does not cause people to be domestically violent, but when we look at people with an alcohol problem, we find that a very large percentage of them may engage in domestic violence. Incarceration can be a result of any of the crimes committed, getting, using, or recovering, or to pay for drugs. There's also a drug-using lifestyle which puts people in contact with gang members, with criminals, and other things. Also a lot of connection between sex and drugs. Some drugs are reported to make people feel more sexual. Some people only engage in sex while under the influence. Prostitution can be a way of paying for drugs, and so on. Often people who have a substance use disorder and a mental health diagnosis are seen for the mental health treatment by someone in that field. But in order to coordinate their care, they're often referred to a support group, self-help group, such as Alcoholics Anonymous. I'm going to give you a very brief run-through of that in this presentation. Alcoholics Anonymous did not begin as a series of meetings. It began as a book. People ordered the book, read it, followed the program in the book, and as a result, many people got clean and sober from reading the Alcoholics Anonymous book. The book includes 12 steps, and those steps can be roughly considered 3 different categories. The first 3 steps deal with problem definition. Steps 4 through 9 involve a process of change, and steps 10 and 12 involve maintenance in order to stay clean and sober, having completed the process of change. When working with someone with a substance use disorder, it's important to consider relapse prevention. Substance use disorders are often defined as a chronic relapsing condition. For example, 70% of those treated for alcohol, nicotine, or heroin will have relapsed within 90 days. It's important to learn to recognize relapse triggers. Those can be either internal, mood states, or external, people, places, and things. It's important to work with the client to define relapse factors or relapse triggers. You can talk to them about self-efficacy, their beliefs about drug use, and what coping skills they might have, which would help them avoid a relapse. The activities which occur in 12-step groups, AA and so on, are largely focused on relapse prevention. This involves creating new habits to use whenever the client is triggered. Instead of going to the bar or the liquor store, they can go to a meeting or call a sponsor. The process of participating in meetings and getting to know other people in recovery helps to build a support system, and listening to other people's stories of how they have recovered helps the client learn to surf the urges. If you think of the urges to drink or use as like the waves on the ocean, they rise, they're high for a period of time, and then they subside. If when the urges are high, the person gives in, that reinforces the addiction. If they can ride out the urge without using or drinking, that reduces the hold the addiction has over the person. In working with people with a substance use disorder, there are great many curriculum, great many interventions, but many of these are available in manuals from SAMHSA, Substance Abuse Mental Health Services Administration, for free. There's one specifically designed, the Matrix, is a curriculum with a great many handouts designed for treating stimulant use disorders. There's also brief counseling for marijuana dependents and so on. All of these are available from the address you see on the screen. Also, for people who work with both mental health and substance abuse, treatment improvement protocol number 42, treatment of co-occurring disorders, which shows a 4-quadrant model. People who are low in one or the other problem and high in the other, or low in both or high in both, and where they are best served by getting treatment. There are some other interventions or treatment models which are helpful in working with people with co-occurring disorders. One is the stages of change model, which is a trans-theoretical model, covers all different theories of how to help people move through the process of changing and then stay changed once they've completed that process. Motivational interviewing is often coupled with the stages of change model, but motivational interviewing can be helpful for any client struggling with a problem which requires them to change their thinking, feeling, and behaving. In using motivational interviewing, the challenge is for the counselor not to try to force a particular point of view on the client, but to try to help build the client's desire to change. So the basics are that you express empathy, but acceptance of the client, unconditional positive regard, does not mean the same thing as agreeing with their current behavior. You want to develop discrepancies that could be the pros and cons of using or not using. Roll with the resistance. Don't think of the clients as unmotivated or defiant or whatever. Resistance is normal whenever somebody is facing a major change. And counselors need to be very cognizant of the need to support self-efficacy, their belief that they can change from being a user to being an abstinent person. Another model which is very helpful in working with people with substance use disorders is the ABCDE model, which comes to us from either cognitive behavioral therapy or rational emotive behavioral therapy. It's a very cognitive technique, but this model is also often used for anger management classes, besides substance abuse and a number of other problems in which there is an activating event, a trigger, which then leads to problematic behavior. More information on the topics of substance use disorder, mental illness, and co-occurring disorders can be found on the Counselor Soapbox YouTube channel. The playlist titled Learning About Alcohol contains 38 videos on that topic. The playlist titled SUD-CD Classes, Substance Use Disorder-Chemical Dependency, contains 30 videos on that topic. The playlist titled Counseling Theories and Interventions currently has 3 videos with more to come. This includes videos on the stages of change model, matching interventions to the stage of change, and motivational interviewing. Thanks for watching. For more information, please visit my blog, counselorsoapbox.com, where you'll find over 2,000 text articles on mental health, substance abuse, and having a happy life. David Joel Miller fiction and nonfiction books are now available on Amazon. This video is by David Joel Miller, some material from counselorsoapbox.com. Photos are courtesy of pixabay.com and Wikimedia Commons and are licensed under the Creative Commons license. This video is copyrighted 2023 by David Joel Miller.